All right, welcome everyone. Can you hear me okay there in the back of the room? Awesome. I am going to echo the other speakers here that I am honored and humbled to be with a great group of individuals today, both on stage and out here in the audience, all coming together on this really important topic of disability health. All right. So a little bit about me and disclosures. I have no financial disclosures, nor am I going after Big Pharma currently. But you've heard a little bit about me. So I'm a physical therapist and I'm from St. Louis, Missouri. And in our department, I am the traditional PT in our community. I am white female of brown hair and brown eyes. I fit about the majority of physical therapists you might see. A little bit more about me. I do currently practice in our pro bono clinic, which is integrated into our DPT education for early exposure and a chance to work with underserved in our community, which I value heavily. I also work in our ALS interdisciplinary clinic. Additionally, I consult for the Institute of Knowledge Translation, so I'm honored to be here as part of this kind of implementation science section of our talk today. I consult for CAN-DO-MS, and I'm also on the advisory board for a really important local organization called Paraquad, which runs a universally designed independent living center and accessible fitness. Personally, it's my family picture. So I am a mother of 2 teenagers. Anyone else has teenagers in the room? I appreciate all your prayers and good wishes. It can be challenging at times. On the height issue, my son outgrew me at 8th grade. I just changed the family picture above the mantle because I didn't want to give up my height. But I have to admit, he's 6 foot. I am not 6 foot. So that's a little bit there about me and my family. I am also a city transplant, which may just be interesting. I'm from a small town in Midwestern Missouri. I remember when we got Casey's General Store. I looked it up. They do exist in Alabama. So there was a big deal because you could get pizza hot. You didn't have to make it from scratch. You didn't have to buy it frozen. Like you could get it within 10 minutes versus additional 30 to 40 minute drive to the closest place. So I'm from a very small town. My superpower relates to that in that often people think I'm from the East Coast because one of my superpowers is I'm really good at talking fast, all right? So this is my call out. If I'm moving too fast, just raise your hand and give me the slow down sign. And yes, I've had people do it with talks before. I welcome it, all right? And I'll do my best to keep us on pace. I do currently live though in St. Louis. So again, I kind of have different worldview, rural and urban. All right, let's get moving forward. So our purpose, my purpose being here today is to really challenge us all to rethink and begin to truly create today the world of healthcare that we want. And specifically, I'm going to focus on physical therapy and neurologic practice and the lived experience of persons in that arena, including therapists. Now, if you're not in the neural PT world, that's okay. I really hope there are pieces that you're going to take from this talk that apply to you. Additionally, I just want to say on that idea of rethinking, I don't think this group needs to rethink. I think this group is already here and is part of really those change agents that are moving this forward. So again, I'm honored to be here and part of such a great group. Our roadmap to get here, so it doesn't have 3 stages and lots of steps, so it's a little simpler. We're going to rethink wellness. We're going to talk about a paper that I was part of published in 2022 in the Journal of Neurologic Physical Therapy Practice that won this little golden synapse award, which doesn't mean much if you're not neuro PT, but it was pretty cool in our world. So I want to share what we proposed in that paper, and the 2 big things in that paper that we talk about are these delivery models for practice, as well as important screenings for healthy behaviors and behavior change. And then from there, we'll have just 1 or 2 slides on future directions as I see them and some takeaways. All right, so here's the rethinking wellness, which you all are kind of already ahead of this game, but bear with me. So the first kind of old view of how we've been with PT is you have to be healthy to be well. And we know that's not true. Wellness is for everybody. Doesn't matter what health condition or what things are on your place. Everyone can and will be well. And working with people living with ALS, I believe that's still to be true. Doesn't matter what's on your plate. We can be well. A focus on just the disability versus a focus really on the ability within that disability. And I have a good story about this, but for the sake of time, I'm not going to tell it. But if we have time for questions, somebody ask me and I'll tell my story then. All right, PT is about recovery and rehabilitation, which is true, but PT is more than that. It's also health promotion, wellness, maintenance, and prevention. PT is exercise with the lovely home exercise program. If you've ever been to PT, you got your piece of paper with your 8 exercises and you framed it and did it forever, right? No, okay. PT is exercise, absolutely, but it is more than that. It's lifestyle physical activity, it's reducing sedentarism, it's increasing healthy habits to support that along the way, and ultimately optimizing movement is really a hallmark of what hopefully defines PT at this time. Our healthcare system is a reactive, sick care, I would say broken one. And I think Dr. Remmer opened with this yesterday, that we want a system that is proactive and that is truly a healthcare system. All right, when we think those things in mind, I thought it was important that we open with a conceptual model that talks about the domains of wellness. And the reason I think this is important is that part of rethinking what we do in neuro PT and what we do in healthcare is we need to think about all of these important dimensions and whole person care. I think that's a consistent message that we're hearing from many people today. I know you can't read those dimensions, so I will quickly read them for you. There are multiple models of wellness. People break it down different ways. This is just one that Adam and Besners did. So the top circle says physical, and if you go around to your right would be emotional, environmental, social, spiritual, occupational, and intellectual. I think it's important that when we're working with individuals and thinking about trying to change health and change health behavior, that we consider all these very important aspects of someone's wellness and intervening in the intersection of these areas to truly move our outcomes forward and actually improve quality. And I will come back to a little bit on that wellness model towards the end. This is the paper that we published in 2022. This was a labor of love of my colleagues that we were tasked from our Academy of Neurologic PT to really help shape this vision. They wanted us, they were hearing from other practitioners, we need more information about how to do wellness. They formed a committee. There are 7 members of that committee. I should have their pictures up there. Apologies, their pictures aren't there, but I'll read their names. So Dr. Miriam Rafferty is the lead author on this paper. You'll see me reference her work as we move forward. Dr. Stacy Fitz, Dr. Karen Hutchinson, Dr. Kimberly Muzak, Dr. Ariel Resnick, and then also Dr. Sandy Billinger. So I want to just give a shout out that it takes a team, it takes a village. Our village worked together for several years to look at the landscape of the evidence and also what was happening in practice. And in doing that work, we landed on 3 things that we came through in our paper, which was truly what is the scope of practice for physical therapy in this area of health and wellness? What is the evidence for health and wellness in neuro PT? And then finally, a really important piece and relates to this topic is what are the knowledge translation tools? What are the resources that we can give people to do something about it today? So the first slide here is just talking about those scope of practice. So 3 things. First, that physical therapies do have it within their domain of practice to address primary, secondary, and tertiary prevention. Historically, PT is pretty good at doing the tertiary prevention. You have a problem, you come to PT, we help you solve it. But when looking at what we're seeing in the landscape of evidence, as well as within position statements from the American Academy of Physical Therapy Practice, we need to get in earlier, right? What are we doing for fall prevention program? What are we doing early on? The second was really, yes, optimizing movement is a cornerstone of PT, and that includes physical activity and fitness promotion. And then finally, that last bucket is that we need to reinforce key healthy habits to really do our primary function of movement well. So we need to reinforce healthy sleep, nutrition, stress management, smoking cessation, all right? And doing these things will help us help people be healthier. What I want to focus here next is the models of practice that we proposed based on the review of the literature that help us do HPW today. So kind of small, I will walk you through it, and it is in the paper if you would like to read more. We basically looked at the literature and looked at practice and landed on 4 models. So little overview, then I'll go a little more in depth, and there's a couple slides to tease these out for you. because this is something I really hope you're walking away with today, either saying, hey, I can do this in my practice, or hey, why isn't my therapist offering me this as part of my care? So the first model is really just your traditional model of therapy. You're going to therapy maybe 2 or 3 times a week for so many number of weeks. That's the first model. The second model is the consultative proactive model. And what I want to highlight here is this is, again, more consultative, more that dental model, if you would. So you're going maybe 1 to 4 visits every 6 to 12 months, so fairly infrequently. Model 3, I can get this slide to advance. Patience is not my superpower. I got a little click happy. We'll stop here, put it down. Model 3 is skilled maintenance, all right? So what's about skilled maintenance to highlight? This is where you're going 1 visit per month, typically, so a little bit more frequently. And then finally, model 4 is really a community-based model of I'm doing something back to engaging 2 to 3 times a week, but not in a traditional PT setting, in my community, okay? All right, to highlight a couple other things about these models, models 1 through 3 are billable service. This is something insurance is gonna pay for, Medicare is gonna pay for, if you document right and it's truly justifiable, okay? Model 4 is a self-pay model that exists in the community. The other thing that I want to emphasize about the models, model 1, that traditional model of practice, is start from the acute care all the way through an outpatient setting, but what's different that we're advocating for is early on we're talking about health promotion and wellness, healthy habits, lifestyle physical activity from the beginning. We're not waiting till 2 to 3 days before discharge, and now we're thinking, no, we're beginning with the end in mind, where do we want to go, and having that conversation early. All right, model 2 and 3, I think one of the key differences between model 2 and 3, besides the frequency, is model 2 works best for someone who usually has a high self-efficacy for exercise. They know what to do, they enjoy exercise, they have a lot of the resources and not a lot of barriers, okay? So if you give them a little bit of a good place to start, check in them infrequently, they're good to go. Model 3 though, on skilled maintenance, the difference here is that often we have a lot more complexity of needs. There's a lot more things going on my plate. I don't have good access to equipment. I have a lot of different comorbidities. I have heart problems. I have diabetes. I need a lot more problem solving and that skilled hand-holding from that physical therapist to help me walk that road, okay? And maybe I have a lot lower self-efficacy for exercise given some of these barriers. The other key thing to note about the skilled maintenance model, and it's right there in the name, traditionally the focus in skilled maintenance is maintaining function or slowing loss of function. And that's an important thing to note because we have to debunk the myth that Medicare only pays for improvement. That is not true, okay? So the Jimbo Sabalas case, many of you may be aware of this, went to trial in 2013. It sounds old school, but it's still coming to fruition that we need to advocate. Medicare covers skilled therapy to both improve, but also to maintain and slow loss of function. Okay, and they have a lot on their website based on that lawsuit that they lost that they need to teach and educate providers and clients about this rule. Okay, and I'll talk a little bit more about that, how we document that in a minute. So that gives you a little flavor. Model 4, just to wrap up here, I mentioned this was not in a traditional setting. Where these models can come into play, it can be at your YMCA. If you've had a good connection with providers in the YMCA, giving people exercising, whatever community fitness that works for them. Another great example is something like, I believe it's Lakeshire here at UAB, or it's the Peak Center in Colorado, or in St. Louis, it's the Orthwine Center, where you have a center that has specialized equipment and exercise physiologists that are trained in adaptive exercise that can be the supports needed. All right, this slide here is super small. I checked the QR code, it could work. So if you're that person you want to follow along, you can scan the QR code. This is a delivery model tree. So after we published our paper, we got a lot of good buzz about the interest in these models. People have been doing it, but they didn't have it packaged and didn't have the language to really bring it forward. But they were still struggling with how to figure out who's a good fit and at what time. So this is a knowledge translation tool that we put together. It is freely available on the Academy of Neurologic Physical Therapy's website. If you have a computer, you can just Google AMPT and HPW, and it should pop up the site. But what it does is it walks you through some key questions along that journey to determine if someone starts in a traditional model of care for physical therapy, how do I determine what model is best for them? Is it that consultative dental model, or is it maybe the skilled maintenance model? All right, and so it walks you through assessing their self-efficacy, asking about barriers, asking about, is there someone else that I can train, a care partner, someone in exercise physiology actually will do just as good a job, if not better job, and is the right person for them. So it walks you through those steps, and I encourage you to check it out as a resource. This slide's a little bit easier to read, so this is a shout out to my colleague, Dr. Miriam Rafferty. And here what she's showing is the delivery models applied to someone living with Parkinson's disease. So I'm just gonna highlight the top and the bottom rows. So the top row is showing the stage of disease progression to Parkinson's. So Parkinson's usually kind of the early beginning stages, a middle, and then an end stage of Parkinson's. And if you look at the early stages of Parkinson's, this can be a good fit for that consultative proactive model. Little bit of disability setting in, often hopefully still high self-efficacy for exercise. If I can get in there early, keep people active, we know there's more and more evidence showing the neuroprotective effects to slow Parkinson's disease with exercise, all right? So that model could fit well there. Let's say that person continues on their journey with Parkinson's, they're developing more mobility problems, some falls. This might be the time to get them in that traditional model of PT. Get them some of that exercises, see them more frequently, and then from there, with discharge, determine, are they back to consultative, or do they need more ongoing care? And maybe they advance at that point to skilled maintenance. The last piece that she has in her slide is on that third piece under end stage, or late stage, Parkinson's, can be a really good place for that skilled maintenance model, okay? And working a lot with people with ALS, we spend a lot of time in that skilled maintenance model. All right. There are some challenges to these models, but we have some solutions, so I'll work through these. First challenge is a lack of awareness that these models and that this is an option within my current healthcare system. So that's why when I got asked to talk, I'm like, yes, I'm gonna come today and hopefully have another opportunity to disseminate this important work and challenge you to have that awareness about these models. Scheduling, so logistics, right? Asking people to come back in 6 months can be a challenging kind of tracking all that piece. So just taking the time to set up order sets, getting a liaison, working closely with your front desk staff, sending reminders, those important things, as we kind of heard from a knowledge translation piece, do the time to set up the processes that help you do the follow-ups. Billing, all right. I already mentioned 3 of those models are a billable service. I will say the maintenance scares your boss. If you're a clinician, they don't like you saying you're doing maintenance because they think Medicare is going to deny. So having that good conversation and working with your team to provide the right documentation. A quick tip that I find in my practice, if I am moving from a traditional episode of care or a consultative model to a skilled maintenance, and my goals then shift. My goal at that point is to maintain or slow function. I discharge my improvement goals. I set new goals. I establish a whole new plan. So when Medicare is reviewing what we submit to them, they can see those goals align with what my outcomes and how that person and I are working together in that therapy session. So really think about clearly delineating those differences between trying to have goals that are improving functions versus goals that are set to maintain and slow loss. The other piece is just good documentation. You have to show, as I see it, that you are using your, in this case, we're talking about physical therapy, so your skilled physical therapy had to clinically reason through that complexity of that person in front of you. You're not just doing the same exercises the same way every day. That's not using our skill service. We are modifying exercises. We're monitoring their vitals responses. We're adapting to new problems, okay? I tell my patients too, when I talk about skilled maintenance, like bring your list of concerns. All right, so if you can tell the therapist, I want to work on this, I want to work on that, I have these questions. And the last one is tracking. So what we're proposing here is remote monitoring can be a good tool. We heard this talk yesterday about the value of telehealth and different ways that we can check in with people in between sessions. All right, A little bit more on tools. So this is another knowledge translation tool, freely available on the Academy of Neuro PT's website. It's called Bridging the Gap. I think there's a whole talk coming up on Bridging the Gap, so that's great. It is a 40-page document, but once you get through it, it's got a lot of cool resources that encourage therapists to talk with clients and partners about what are their values, what's important to you, how do these models work. There is a nice little schematic that my colleague Karen Hutchison did where you have all the exercises you're doing in therapy. You can click the box, you can take it then with a nice warm handoff to the YMCA or to the Paraquat Orthwine Center. So some of this work is here for you. Don't have to start from scratch. All right, with my remaining 5 minutes, I'm gonna talk a little bit about the behavior change piece, but hopefully you got a good flavor on those models, which was really the important thing I wanted to talk about. It's hard to see the citations that are listed here. There's 3 papers. The first 2 just really talk about the evidence that supports the health behaviors I'm going to speak to. That's the first one from Besner. The second one is from the clinical practice guideline that just came out for Parkinson's disease. It says we must do behavior change in our implementation work. And then the third one says from Fritz's paper in 2023, physical therapists think we're doing behavior change, but we're not doing it that well, okay? We struggle sometimes in PT. We are taught to look for problems. I put on my fix-it hat. You got a challenge. I'm going to do it. Health behavior change is putting on your coaching hat. It is working side by side with helping people to challenge and fix their own problems. We don't always do so, guys. Switching hats. So I'll give you some resources. But first, based on the evidence, and this is a table that's on our website, keep saying that, it shows these are the 5 behaviors that I spoke to earlier that I think every PT should be screening in every encounter they have. So at least every episode of care. Physical activity, nutrition, sleep, stress and mental health, and smoking. Okay, there's more and more evidence about how these factors relate to health outcomes. We know that those who smoke that have MS, that will increase the disease progression. Okay, so these are important pieces that impact someone's health and impacts their engagement in exercise and success in rehab. Across the top, we have screening questions. If you're like, I don't know how to talk to somebody about smoking, or I don't know how to talk about their stress or nutrition, there's an example of screening questions. And then if you really like numbers, there's outcome tools that you can go in further depth. And then most importantly, if you screen something, you need to know where to go from there. If there's a positive screen, what's that next step? What's that action? So there's resources to connect in with in the community or the right provider, okay? I chose to highlight just briefly the physical activity. Wanted to point out, as I alluded to, that we're hopefully not just doing HEP's home exercise program. We're looking at that total fit prescription, that frequency, intensity, timing, and type. And then that VP is volume and progression or regression. So what is the total volume of activity that someone is doing in a day that they should get credit for? Right? So these are just tools, an example of how you can use self-report tools or step counters or diaries to capture overall volume of physical activity and sedentary time, and using those to establish a baseline and track change over time. I didn't see how well my step count did today, but it's not bad because I did walk over here from the hotel. All right, so these are resources. I mentioned that therapists don't always do so good putting on their coaching hat. So this is another, again, knowledge translation tool. This one is highlighting on that, my right, your left, motivational interviewing. So you've heard of motivational interviewing? So many of you have, right? So this is one of the best evidence-based counseling strategies that helps people move from that place of ambivalence, like, yeah, I kind of want to exercise, but I'm not really sure. These are the ways to overcome barriers and move people forward. So that's an example of a resource. The other piece on the side is hard to see. This is called the CARE measure. Has anyone heard of the CARE measure? Okay, didn't think so. This is from the UK, 1 or 2 people. What I love about the CARE measure, this is a tool for practitioners that you can give someone that you're working with, and they evaluate you and how you did in connecting with them and wearing your coaching hat. So for example, some of the questions on there ask the client to say, how well did your provider let you tell your story? How well did you feel listened to? How well did the provider work with you to develop a plan? All right, so they really hold us accountable for bringing those knowledge translation tools. Last tool is just thinking back to that beginning part about wellness. This is from the Enhanced Medical Rehabilitation Study that was done at WashU that looked at if we really take the time to establish what are people's importance, values, and goals, we can develop more effective plans of care. So this is just a card sorting activity that I really like, that people can sort out what activities are important to them, get to know about them as a person, what connects them, and then you can establish how to write meaningful goals. There are other tools that you can do that as well, things like the goal attainment scale or the patient-specific functional scale. All right, I have 2 last slides and no time, but I'm going to quickly just do these last 2 slides. So actually, I passed over one. The summary of this slide says we need more research, okay? And it says we need to connect better in our communities, all right? That's what that slide says. This slide, I'll take the time. So first takeaway, wellness is for everybody, and everybody has a role in doing wellness. The HPW delivery models can help individuals maximize their health and wellness with the right supports at the right time. So I encourage you to use them. I believe, and based on the evidence and others, we should be screening and addressing for those 5 healthy behaviors in PT, not just physical activity, but those others that I mentioned. We should learn and use evidence-based behavior change strategies and hold ourselves accountable to actually doing it and assess ourselves and our abilities. And finally, I think it's important that we connect and grow our community and professional practice resources to create that healthcare system that I believe we all here want today. So thank you for your time, and I'll take any questions whenever it's the time to take questions. So thank you.